Welcome to the CodeCast Podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast Podcast today. My name is Terry Fletcher. I hope everyone is having a good March so far. This is the 229th episode of the CodeCast. And today my topic is going to focus on when you can bill an E&M service, so an office visit, on the same date as a minor procedure. We know there's a Medicare rule about this, and it's pretty strict actually. There was also an OIG work plan that was focused on dermatology, but what about other specialties and other services performed on the same date as an office visit? We get denials on this, so let's take a look at it when it's appropriate for different specialties. You may or may not agree, so I'm going to give you best practices along with best coding tips so that your claims are not only clean, but you're also not spinning your wheels trying to get payment when you may not be entitled to it or the payer may balk at it. And I don't want you to waste your time. But also we want to make sure that it's clear when you need to fight for that claim for reimbursement. So we want to just take a look at some things that maybe you didn't think of, or just some things that could help you in your processes when you submit a claim, when you code for something, and when you're talking to your providers saying, hey, this is what I need to see in the documentation to be able to code for this. So I'm going to start with injections, joint injections. Billing for an E&M service on the same day. Sometimes you can get paid, sometimes you can't. So let's really talk about this when this is appropriate. So let's say the provider sees the patient for the first time for a complaint, okay, not a condition. You notice I said that, a complaint. They work them up with the history exam. The medical decision-making is documented, and the decision for the injection was made at this visit after considering and discussing options for the patient. Maybe the option could have been surgery, maybe it was pain management, maybe it was just let's see how we can do conservative treatment with the joint injection or even physical therapy. And what's helpful here, and I want to be clear on this, why are you considering other options except for just the joint injection? Is the patient a diabetic? Is the patient a Coumadin patient? Are there medicine interactions that you were concerned about? Well, if you document that correctly, now you have an E&M service plus the injection medication and the actual injection code. So in the around the 206 code series, 206-100, and then so on. So make sure if it's large, medium, or small joint, and if you had ultrasound access or ultrasound guidance, I should say, just make sure that you expand on why you needed to have that workup on the patient to bill the E&M. And it's not just about making the decision for the injection. It's about why that decision had to be made in the way you did it. Let's say it's an established patient. This is the biggest, I would say, denial we get when we do an injection on the same day. So physician sees a patient for an established problem, and there hasn't been a recent evaluation for this. So it's an established problem, but you know what? The patient really never brought it up before. Again, a problem pertinent history exam and a medical decision is documented, and a joint injection is made at the end of this visit, discussing options. Can you bill for the E&M service? As long as there was no predetermination, you should be able to. And again, the same as for a new patient, you want to make sure that you're documenting why you are seeing the patient and what is the workup entail. Again, what are the other risk factors? What is the reason the patient wants to try an injection versus conservative treatment? That's what's really important to show the medical necessity for the E&M service. So let's say the patient presents for an injection after a recent evaluation in one of the situations where they went and, they had x-rays or an MRI or some kind of diagnostic image, and there was an E&M encounter, and the patient said, let me think about what's happening. I'm not sure what I want to do, but the doctor recommended injection. And then, or maybe they did physical therapy for, let's say, 10 visits, and they said, I'll consider an injection, but I just really want to try the PT first. Or let's say after consideration, the patient decided that, I'm going to go forward with the injection. They call for an appointment, and you usually will see this in the record. It'll say, patient presents for an injection, or patient here has decided to go ahead and with the injection based on the last visit, something like that. Well, what can be billed that day, even though there probably is a discussion with the patient, are you sure you want to go through with it, and maybe a reminder of what the injection is going to be, that is only the injection code billed and the medication. So make sure that you're not billing an E&M in that scenario. The next one would be any procedure, and we're just talking about injections right now, when prior to that encounter, it was already decided that the patient is scheduled to come in for that injection, or again, what we call a minor procedure. So whenever it's pre-scheduled, even if there is a brief discussion or any kind of pre and post work on that injection, just know that is a patient that it's already determined that that's what they're going to have, and you can't bill for an E&M. If you try, just because the patient or the physician had a conversation with the patient, you will probably get a denial. And if you don't get a denial, at some point somebody will want to review it, and then you'll have to refund money, which is a nightmare. So keep those guidelines in mind when we're talking about E&M services. So let me switch gears a little bit. Let's talk about gastro. What about a patient that is coming in through the ER? They've got a GI bleed, and the doctor takes them in for a colonoscopy. Well, that's a minor procedure as well, 0 to 10 days on colonoscopies. Can you get that E&M paid? Well, if a patient's coming in for any kind of GI bleed or any kind of rectal bleeding or anything like that, the doctor right away doesn't know what it is. So they have to work them up to determine, what is that? Could it be an ulcer? Is it, GI related, colon related? What could it be? And so in that case, the doctor's documentation, because now we're not in outpatient 2021 rules anymore for office visits. We're now in hospital visits, ER possibly, or admissions if that's what they decide to do. And so now that workup has to include a full-blown H&P, if you will, if they're going to admit them or, make that determination. And so to be able to bill for that, they have to show the causal effect. So why are they coming in, a pertinent history on that patient, any kind of family, past social history, a full and complete physical exam related to the presenting problem. Risk factors are a big deal. And then the medical decision-making on why they proceeded with that particular minor procedure or diagnostic. A colonoscopy is both. It can be therapeutic or diagnostic. So let's take the patient, I always kind of circle back to dermatology only because there's always a controversy here. And I have several dermatology clients that we get into some discussions about this, and I hate to say I'm usually correct, but let's just say more often than not I'm correct from a payer perspective. And that's my job, is to say, okay, I may agree with you that something may be important for the patient to have. All I'm telling you is that it doesn't follow the definition or the guideline from the payer contract, whether it be Medicare or private payer, that says that that's medically necessary and payable. So we have to know the difference for that. So let's say that you have a patient that had a total body exam, let's say a month ago, and there were some suspicious lesions that the doctor said, or skin eruptions, that we're going to go ahead and take care of when you come in the next time. So patient schedules an appointment for a month later. They come in and they have those removed. And actually, let's say that 2 lesions were removed by tangential biopsy and the other one was removed by shaving. Okay, so one was basically getting a tissue sample and the one was actually a biopsy that they needed to send a path. Okay, so then what? Well, if the conversation or the documentation basically was all about that scheduled procedure, then there is no E&M service. When would there be an E&M service? Well, let's say the patient didn't have that scheduled. They didn't have a previous exam. They're coming in for the first time, and this is tricky because there is a rule in Medicare that says even if they're coming in for a new patient, this still may not be appropriate. But let's say that there are some risk factors, and risk factors are huge when you talk about having to evaluate the patient first. Again, diabetes, because diabetic patients who get cut into, and I hate to put it that way, but have anything where they could start bleeding, or Coumadin patients, you don't want to do that. So those are, they're on blood thinners. You have to be careful with that. That has to be stopped before you go there. But diabetic patients take longer to heal. Patients that are smokers, this is a huge problem in derm. Patients that don't realize that they've had excessive sun exposure, and this could actually be a deep biopsy, and we have to look at margins too and have a conversation about spreading. So these are things that absolutely warrant an E&M service, 25 modifiers, and anything that I've talked about as well, that lead to a minor procedure on the same date. So pre-scheduled is really tough. Let's switch to cardiology. So let's say that you have a patient that came in and they had an EKG and a new patient visit. Okay, EKG on a new patient, you never have an issue there. They're like, oh, it's cardio, you're going to get paid. But let's say that the patient comes in for a second visit. Their patient has known cardiovascular disease or, CAD, and the patient, because your office routinely does EKGs on every patient, they're coming in for their 6-month follow-up and you do an EKG. Well, unless they have a new complaint, a new symptom, a chronic condition that warrants monitoring their heart problem because you had a past history of there being an abnormality, there shouldn't be an automatic EKG. You can't routinely perform services just because you have it. And that's the big thing. You need an indication. You need to reflect medical necessity. And the biggest thing on these services is established patients. New patients, yes and no, we have some challenges, but established patients, it's crazy how many denials we get on this, especially when there is either a routine service that's billed on the same date, or it's already a scheduled service where the patient's coming in now for, I mentioned orthopedic with injections, or they're coming in for a scheduled colonoscopy, or they're coming in for a scheduled E&M services, and you just happen to go ahead and do a routine EKG. Let's say your primary care, and every time a patient comes in, I saw this recently, you decide that every single patient needs a B12 shot, or every single patient needs a screening for something. You can't have routine services without working the patient up to determine if they need it. And medical necessity is a really big deal right now. So be careful with trying to bill for things on the same date where you don't have specific justification to do so, or where there was a predetermination that the patient was going to have the minor procedure and they were coming in for that procedure only, and all of a sudden you're billing for a visit. Now, are there times when you can bill for a visit when they have a scheduled procedure? Of course, if there's something unrelated, or we like to call them by the way visits. And so let's say, let's take general surgery, for example. Let's say the patient's coming in and they're scheduled for a incisional biopsy in the office, incisional breast biopsy. The doctor wants to take some cells. They're just not sure. They thought maybe it was a clogged milk duct from a nursing mother, but actually after palpation, they found that it actually is something that they want to do an incisional biopsy, not excisional. They're not taking it out. They're just making a tiny opening and pulling out some cells. So incisional. That's 0 to 10 in the office. Well, let's see why they're talking. The patient is also talking to the physician about some lower extremity edema and swelling that they're having in their right lower leg. And they're talking about compression stockings and some things that could help with that as they're doing this other procedure. Is that a billable E&M service as long as there's a full workup on that patient? Yes, that's a completely different diagnosis, unrelated to the incisional biopsy. And as long, again, as there is a complete workup on that patient, E&M components that we can support, then you would have an E&M service, a different diagnosis of the 25 modifier. Now, I realize that the CPT book says you don't need a different diagnosis of the 25 modifier. I don't know who put that in there, because obviously somebody that doesn't work with payers on a daily basis like all of us do, and somebody who has too much time on their hands. But you want to look at that as maybe a fallacy. So if you have a new complaint, if you have a different diagnosis, if you have something that says significant separate service, remember that's what the 25 modifier is. You're showing that there's a significantly separate identifiable service. And how better to do that than a different diagnosis? So I can't tell you it's mandatory, but I can tell you it makes it easier for you to get paid on both services if you can reflect the E&M was for one service and the minor procedure was for another. Now, the last thing I want to talk about in this split situation with procedures and E&Ms on the same date is when you have the preventative service and an E&M code. So I've done a whole webinar on this. So I'm just going to touch on this and then find my webinar on it. But what if you have a patient who is coming in for preventative services? They're coming in for their PAP and pelvic. They're coming in just to go over their risk factor modifications and maybe get some, prescription refills on birth control, etc. Okay, so I just talked about primary care, internal medicine, family practice. And during that visit, the patient has a complaint about something. Can you get a new visit out of that? The answer is maybe. Does that complaint warrant a new workup on the patient and maybe ordering labs, tests, or diagnostics? More than just labs on screenings, more than just labs on routine, how are you doing? Let's just do a UA, let's just do a cholesterol check. More than that, it has to be something where, maybe they're saying that they're finding that they have a possible nerve damage in their wrist. Should they get an EMG because they think they could have, persistent carpal tunnel or something? And your doctor noted that the patient does have osteoarthritis, and so maybe this could be something that's reflecting a severe flare-up or an exacerbation. Then yes, that could be a separate E&M service, again with a 25 modifier. And in that case, I would put it on the E&M, not on the preventative service. But the patient could have two copays, so be careful with that, because when patients come in for preventative, usually they think there's no copay and there's no out-of-pocket. And so always be mindful of that if you decide to split or share that that encounter, because you'd have to have two separate workups and the patient will have a share of cost because now you have a preventative and a problem-oriented visit. But the CPT book is clear. It has to be significant enough that means that you have to move on from your preventative and work the patient up through a problem-oriented visit. And if you're not doing that, then it's just incidental to the preventative. So keep that in mind. And I know it's a fine line sometimes, but just keep that in mind, because that can be tricky when it comes to getting paid for both, and then tricky when it comes to the out-of-pocket for the patient. Okay, so those are kind of the points I wanted to touch on today. The CodeCast is also brought to you today by Gold Bond Ultimate Healing Lotion. Skin therapy for nourished, healed, and healthy-looking skin. Gold Bond Ultimate. Also, for those of you looking for a telehealth tune-up, I like to call it, check out my website as I have a new on-demand webinar for the current telehealth rules and reminders during the last of the PHE. And I don't know if you've been noticing the news or Twitter lately, they're lifting almost all of the protocols, the testing, the masks, everything is getting relaxed. Everything's coming up. We're seeing, I saw a 43% decline in cases, and hospitalizations for COVID are down over 30%. So it looks like we're coming to the endemic on this. There's always, obviously we're going to have to live with some of it, but just be aware that there's some things that we're looking at in the future. We may not see a renewal of that public health emergency in April, but also some insights on what commercial plans are doing. You can find it on terryfletcher.net under webinars. Also, for the new podcast listeners and my existing listeners, thank you again for sticking with me the last 4.5 years. One thing I wanted to mention, don't forget, if you'd like ongoing coding assistance, please check out our Coding Corner membership under the service tabs on my website, terryfletcher.net. This is for unlimited coding, billing, and compliance questions for a yearly fee through email. If you're an executive member, I also have a quarterly Zoom Ask Me Anything call. That's very fun and informative. We have one last week for my executive members, and anybody gets to sign in and we talk for about 30 minutes, and anybody can ask a question to say, hey, we have this. So I give you also an option if you're an executive member, not just for email. But I just wanted to make sure that you're aware that I'm getting a lot of questions, follow up from the podcast. And I appreciate all of you, but this is what I do. I'm a consultant, so we do have a membership for questions, because I like a paper trail. We research the information for you. We make sure that it's accurate, and that's my job. So we charge for what my job is, and just want to make sure you're aware of that. So I wanted to end my personal tidbit this week, and I think you're going to be happy that I'm reminding you. If you're a state that participates in daylight savings time, we turn our clocks ahead this coming Saturday night. So basically, it's at 2 a.m., but so it's kind of Sunday morning. But when you wake up Sunday morning, you're going to be an hour later if you didn't turn your clocks back right before you went, or clocks ahead, I should say ahead, right before you went to sleep. So remember, spring forward, jump forward, and the fall is that you fall back. That's how I remember it. Spring forward, fall back. So you're going to turn your clocks ahead 1 hour. And if you're like me, don't forget to set your automatic coffee pot. Otherwise, you'll get up at 7 or 8 o'clock in the morning on Sunday. Where if you sleep in, it'll be worse for you. And you'll have no coffee made because it's actually an hour ahead, and it'll say it's only 7 o'clock in the morning instead of 8. So just make sure that you change everything, especially your auto sets for your time. All right, that's it for me this week. So make it a great day, make it a great rest of your week, and I'll talk to you next week on the CodeCast Podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.